interesting webinar today. Our webinar title will be How I Treat AML Incorporating Novel Agents. We have a very distinguished speaker today, Dr. Giovanni Martinelli, who is an associate professor in hematology in the Department of Diagnostic and Specialty Medicine at the University of Colonia. He's a well-known figure. He's an editor-in-chief of hematology reports and one of the reviewers of very high-impact journals, such as Blood American Journal of Hematology, Leukemia, Annals of Hematology. He's also an active member of the American Society of Hematology, European Hematology Association, and American Society of Oncology. Dr. Giovanni will speak to us about an interesting topic, which is incorporating the novel agents in the upfront therapy of AML. We would like to thank the SSBMT for arranging this session. Also, we'd like to thank Astellas. Welcome, Dr. Giovanni. The floor is yours. Please go ahead.
Thanks all. First of all, I would like to thank for the kind invitation. I hope you are hearing me. Please give me a feedback that you are hearing me very well. And
yes, we can.
I'm a scientific director of Istituto Scientifico Romagnolo for the Studio e la Cura dei Tumori. And as my presentation, okay, is not a full screen, however. Okay. This is my disclosure. I have a consulting relationship with several pharmaceutical industry, and this is my disclaimer. I'm not a cell employer. I was involved from the beginning of the clinical development of several compounds that has been developed against patients with acute myeloid leukemia with FLT3. During my overview, I will touch the presentation of a RATIFY study with midostaurin, SORAM with sorafenib, QuantumR with quizartinib, Protocollo Viale A with venetoclax, and finally the ADMIRAL Gilteritinib and ongoing clinical trial. It is clear that we get an unmet need for patients with FLT3 positive acute myeloid leukemia. This is a very important disease since acute myeloid leukemia is an heterogeneous hematological malignancy associated with a lot of gene mutation. We find every time from 6 to 7 mutations in each patient with an acute myeloid leukemia. Sometimes there is a very robust presence of mutation and genomic alteration, but the most important one is the FLT3, which is an overall 37% mutated in acute myeloid leukemia, sometimes mutated together with the second one, which is the 29 and 23% mutated in the majority of the patients. When we have an FLT3 internal tandem mutation, we get a negative impact of prognosis. The disease became refractory, and most of the patients has early relapse within 6 to 12 months. Every time we get FLT3 internal tandem duplication, also this highly recurrence of leukemia. And also when we have a high risk of cytogenetic, we get a high impact in negative for prognosis. FLT3 is the most common identified gene mutation in acute myeloid leukemia, and we get two types of mutation. The internal tandem duplication, which is associated with a small repetition of small bases or one single identified mutation in so-called TKD, tyrosine kinase domain, which confers an superactivation, autoactivation of the entire receptor, which is an immunoglobulin-like receptor. And we get internal tandem duplication in 30% of acute myeloid leukemia and 7% of acute myeloid leukemia has only TKI. So this is associated with a very dramatic outcome in the acute myeloid leukemia. We have to consider it every time. I don't know what's happening in Arabia, but in Italy, a lot of researchers search the FLT3 status and the mutation, but they search the FLT3 mutation just only at the beginning of the disease, at diagnosis. And if they find out that it is negative, they don't search again in relapsed refractory population. I would like to remember that at least an additional 15% of the cases became FLT3 mutated. So the internal tandem duplication, which is at the beginning of the history, is roughly 25-23% of the cases, became 45-42% when they relapsed. So I suggest to my colleague to every time to check again when the patient relapses the FLT3 status. And this is important because you have to consider it to test AML patients to confirm mutation status at relapse. More important to be able to treat the patient with now effective drugs. This is associated FLT3 mutation with a very dismal prognosis, either overall survival or like overall survival in relapsed population. When the patient relapses, you see the outcome of this population. If there is FLT3 mutation, is very, very dismal. And this is very important to go in a first, my summary of my part. Mutation in FLT3 are the most common mutation in acute myeloid leukemia. FLT3 mutation is an independent factor that has a high negative impact on prognosis. And molecular testing for FLT3 mutation in acute myeloid leukemia is a very important risk assessment and treatment decision to be done every time a patient has an initial relapse refractory. So test the FLT3 every time you get cases of acute myeloid leukemia, either diagnosis or in relapse refractory. What is actually the treatment landscape of acute myeloid leukemia? As for other drugs, the beginning was monotherapy. We tested several inhibitors in a monotherapy in a relapsed refractory population. And then we move on to the combination of chemotherapy plus inhibitors. I was involved in the RATIFY several years ago. It was in 2008, in which we demonstrated that using of midostaurin plus 3+7 chemotherapy was able to demonstrate an increase in overall survival, which was roughly associated with 7-8% of this population. You can see that even event-free survival with midostaurin was good, but was good particularly at the beginning of the history when we get the possibility to treat the patient with these drugs in combination. This was a randomized clinical trial in which it was demonstrated that midostaurin was superior if associated with 3+7. But you can see from this curve that a lot of patients lost their life or lost the leukemia-free survival in the first 3 months of the treatment. So midostaurin was consistent active in the majority of internal tandem duplication low, and TDK. All these 3 categories were sensitive to the treatment, and this makes possible the registration of the drug in Italy and Europe and worldwide. It was also clear that treatment with midostaurin and then transplanted in first remission due a lower MRD pre-transplant was associated with a better outcome, which was demonstrated and presented by Richard Stone in New England Journal of Medicine. And another drug which was extensively used also by me and my center was the sorafenib. Sorafenib is a good drug for FLT3. Is associated with 3+7 versus placebo, and the German group presented recently, not really recent, enrolling in the Lancet Oncology of 2015, that event-free survival, if treated with sorafenib, was associated with a better outcome, but not associated with an overall survival advantage. And this was related to the fact that at the end of the day, we were unable to eradicate the disease. And that is what I mentioned. Good response in event-free survival, but not sufficiently to demonstrate an advantage as an overall survivor. I was also extensively involved in the quizartinib development. This was our publication last year in Lancet Oncology, in which we demonstrated in relapsed refractory population that the primary endpoint was able to take the opportunity to be advantage if patients were treated in the monotherapy with quizartinib versus salvage chemotherapy. It was 2-to-1 randomization, but you see that the advantage in overall survival was 6.2 months versus 4.7 with the salvage, whatever is the salvage chemotherapy. It was the advantage was at 12 months of 7 patients. We get 7 patients more alive, still alive, if we treat this population, relapsed refractory, with this kind of drugs. And this makes possible the registration of the drug in Japan, but not in Europe, not in the United States, and not in my country, Italy. So clear advantage of the population to be treated with FLT3 inhibitors, but we were unable to demonstrate until now an overall survival advantage. And this is another approach that has been extensively used in the last year in acute myeloid leukemia newly diagnosed, ineligible for chemotherapy, using AZA plus venetoclax. And we were able to demonstrate that there was a strongly advantage in CR/CRi percentage with AZA plus venetoclax 66 versus AZA plus placebo only 28, with a complete response percentage 37 versus 18, and CR by C2 cycle 2 percentage was 43 and only 8 in AZA, made possible in the majority of the case to demonstrate that AZA plus venetoclax was associated with overall survival 14.7 months versus only 9.6 months with AZA alone. This was a very intensive discussed approach to acute myeloid leukemia, which made possible in the majority of the cases to prolong survival with unfit population, regardless the status of FLT3. And recently, me and my colleague, together with Alexander Baer, George Cortez, other colleague, and Mark Lewis, we were able to demonstrate that another drug, Gilteritinib, significantly prolonged overall survival in patients with mutation, relapsed refractory, acute myeloid leukemia. And these results were presented by New England Journal of Medicine by my colleague Pearce 1 year ago. That was the first cases in which we were able to demonstrate an overall survival advantage in relapsed refractory with one compound. I would like to remember that this was associated with a clinical trial that we designed and we conducted. The ADMIRAL study design was associated with a phase 3 open label, multi-center, randomized clinical trial. We enrolled 2-to-1 patients adult patient with relapse or refractory FLT3 mutated acute myeloid leukemia, enrolling 371 patients. We treated the patient randomized with Gilteritinib, 120 milligrams daily, pre-planned interim analysis versus savage chemotherapy. Whatever is the best decision of the clinical the clinical doctor to treat the patient with savage chemotherapy. Low dose of cytarabine, azacitidine, or MEC, or Flagida. And full analysis put the primary endpoint in overall survival and CR/CRh. FLT3 was confirmed by Leucostrat CDX FLT3 mutation assay provided in Italy by Sofia Genetic, I suppose, in the world by InVivoScribe. And this was a very exciting clinical trial that I'm proud to be part, to have been part. I would like just to remember endpoint assessment, which were overall survival, CR/CRh. Then there was some key secondary endpoint, event-free survival, CR rate, CRc, patients report fatigue, and safety and tolerability. This drug is comes from a previous phase 1 dose finding that we conduced, and we find out that 120 milligrams and 220 milligrams were very well tolerated in the majority of the patients. So in the ADMIRAL, we find out that the key eligibility criteria, inclusion criteria was primary acute myeloid leukemia and AML secondary to MDS. So both population, either the de novo acute myeloid or acute myeloid leukemia secondary to MDS, we enrolled in the protocol. They have to be refractory relapse, including first hematological relapse, after first-line therapy, intensive or non-intensive, with or without hematopoietic stem cell procedures previously conducted. All the people are to be FLT3 positive ATD, TKD with MUT835 or TKD with I837, the more frequent mutation of TKD. Echo performance status has to be below 2. Eligibility, the patient has been eventually eligible for pre-selected savage chemotherapy. And that was the population inclusion criteria. And the basic characteristic, all the patients, 371, median age was 2. There was equal composition of male and female. Mostly of the cytogenetic risk status were associated with intermediate, 73%, but there was a quite important number of patients, 10%, with unfavorable cytogenetic analysis, and just 1% of favorable. Mostly of the patients has been previously treated with anthracycline, 12% with a previous FLT3 inhibitor, 19%, 20% roughly previously transplanted. All the patients, 60 were relapsed, 39, a lot, were also primary refractory without an allogeneic bone marrow transplantation. 60% were previously treated with intensive chemotherapy, and 88% as ITD only, and 1.9% as both mutation. The overall survival was absolutely in advantage for Gilteritinib. Gilteritinib has given, with 120 milligram data, gave a median overall survival of roughly 10 months, 9.3 months. A savage chemotherapy has only 5.6 months, which was censored a statistically significant difference, with 37% of this population still alive by treatment harm after 12 months from the starting of treatment, just only 17% in savage chemotherapy. And this was associated in all the analysis, subgroup analysis of overall survival for each of these age, sex, race, baseline, ECOG, region, central FLT3 mutation status, prior use FLT3 inhibitor, and so on, cytogenetic risk status, response to first line, all these parameters were associated with an advantage in the gilteritinib arm. ADMIRAL co-primary endpoint was CR/CRh. We were able to demonstrate that there was 13% CRh, but more important, 21 of this population were CR, complete CR, with a cumulative amounts of CR/CRh of 44%. In the savage chemotherapy, this was only 15%. There was also a great advantage not only in CR/CRh, but in cumulative CR/CRh analysis. Transfusion dependency, which was a baseline status 70.8 of the transfusion dependent, became 34 post-intervention with gilteritinib. So there was an advantage in became transfusion independent in roughly half of the patient treated with gilteritinib, giving an additional advantage for elderly patient or unfit patient with comorbidity treated with gilteritinib. The safety profile was very good. Before starting this web webinar, I was together talking with the colleague of Arabia, and I was talking about that these drugs is very, very well tolerated. The majority of the patients take the pills at home. Is a oral formulation, which is very extensively well tolerated in the majority of the patients. You see that the only grade 3 were associated with anemia, thrombocytopenia, platelet count, and neutrophil count disease, as in savage chemotherapy, probably a bit less, but it was associated mostly at the first cycle and the first week. Then the patient became transfusion independent. Most of the patients recovered the hematological status, and so the hematological tolerability of the drugs was very good. You can see at the end of this that there was no vomiting, no decreased appetite, no abdominal pain in the majority, just grade 1 or grade 2. Roughly in the savage chemotherapy, we get more stomatitis and sometimes more also blood alkaline phosphatase, nausea, and hypokalemia in the majority of the patients treated with conventional chemotherapy. I move on to finish my presentation on ongoing clinical trial in acute myeloid leukemia. And there was at least additional study which are ongoing in the world, and this also in Europe. The more interesting, in my opinion, is venetoclax plus gilteritinib in relapsed refractory population, which is now in phase 1, phase 2. The data has been presented recently at the ASH meeting by my colleague Naval from the MD Anderson Cancer Center. Absolutely intriguing and very, very exciting. So venetoclax plus gilteritinib and venetoclax plus gilteritinib potentially tomorrow with azacitidine will be probably the best treatment for acute myeloid leukemia, not only in FLT3 positive, but we hope also in other disease. There is also an ongoing study with 3+7 conventional chemotherapy plus gilteritinib, ongoing phase 1. It is a Nordic Europe program in Germany, in Netherlands, but we are waiting for the data. There is another clinical trial which is also ongoing in Europe, in the United States, gilteritinib versus midostaurin. I personally believe that there is no way to compare these drugs. Gilteritinib is marvelous tolerated. Midostaurin is less selective and less well tolerated, but this is just my opinion. And there is also a pre-ECOG gilteritinib versus midostaurin clinical trial ongoing in the world. In Italy, we get for a long time expanded access, getting a study of gilteritinib FLT3 mutated relapse refractory acute myeloid leukemia or FLT3 mutated acute myeloid leukemia in complete remission with minimal residual disease positivity. This permitted with a lot of my colleagues in Italy to get experience, to take experience with this drug, which is associated with a prolonged response, overall survival, as was in the ADMIRAL study. Now the drug is approved in Italy, not completely fixed the reimbursement, but this was an absolutely very important issue. So in Italy, we get now the possibility to get experience and now to get the drug available for our patient. I would like just to remember that there is an additional clinical trial ongoing, the so-called Quantum First, which is a clinical trial in which we are testing chemotherapy plus quizartinib. I was involved in this versus placebo in newly diagnosed FLT3 acute myeloid leukemia. Treatment this patient with cytarabine plus daunorubicin or idarubicin plus quizartinib versus cytarabine daunorubicin versus placebo. We are waiting for the results for the end of the next year. And then I would like to thank you for your attention and opening for answering eventually your question. My conclusion is that Gilteritinib make a new opportunity for our patients, and this could be probably the more advanced drugs in FLT3, acute myeloid leukemia, relapse, refractory, and in the future, probably from the beginning, also in de novo and untreated AML patients. Thanks for your attention.
Thank you very much, Dr. Martinelli, for this elegant talk. Now we'll move to the Q&A session, and I'm seeing some questions here. So a question from Dr. Mansour here, I see it. So in the ADMIRAL trial, and also I noticed that only 12 to 13% of patients have been exposed to prior FLT3 inhibitor before. So you know that currently we are testing upfront, and if midostaurin is available, we are using it upfront. So if midostaurin is being used upfront, how do you think the result of the trial will change?
Is this the question that you're asking me, Mansour?
Yes.
Would the response still be the same in this cohort of FLT3 exposure? I suppose yes. There is a at the ASH meeting of this year, we presented a new update of the ADMIRAL, in which we were able to demonstrate that also in the patients previously treated with FLT3 inhibitors, the response to Gilteritinib is the same. So it doesn't matter if you treat the patient in first line with the midostaurin or sorafenib, and then you move when relapse refractory to Gilteritinib. The rate of response was totally identical. So Gilteritinib is able to overcome eventually mutational clones that confer resistance to previously FLT3 inhibitor.
So that brings me to the second question. Why were 85% of the patients in the Gilteritinib trial not exposed to prior FLT3 inhibitor? Was it an acquired mutation in most of the patients, or was it because the drug was not approved yet? What was the reason for that?
No, in several countries like Italy, at the time we started the ADMIRAL study, midostaurin was not approved. So we arrived later with approval. So not all the patients enrolled in the protocol were previously treated with midostaurin since it was not available.
Okay, clear. I see questions coming
but
here.
It's not obsolete. It's becoming obsolete. There is a quite huge amount of patients. I suppose, if I remember correctly, 27 patients previously treated with FLT3 inhibitors that they respond identically in the same way to Gilteritinib.
Okay, I see a question here from Dr. Al-Askar. what do you can you elaborate more on the current trial combining venetoclax with gilteritinib, which was presented in the ASH?
Yes, the venetoclax plus gilteritinib that has been presented at ASH is being related to the population which relapse refractory 2 or more. So the majority of the patients has previously 2 CR and then they lose. So it's a quite heterogeneous population treated only in one center, MD Anderson Cancer Center, in which they compared venetoclax plus gilteritinib. And that was presented by Nadal. It was there is a previously presentation of few data in April this year. I don't remember the congress where Nadal presented, and now there is an update in the ASH meeting. So you find very well the abstract which has been presented. Is associated with 54, 56, if I remember correctly, CR rate. So it's quite the same rate of gilteritinib alone, and then give probably a more deep response with the majority of the patient obtaining not only CR, but also the molecular CR in the majority of the case. So venetoclax is probably a good drug to be combined because it touches the leukemia stem cell and make possible an eradication of the disease that is important in our patient.
Okay. Another question here I see it from Dr. Mansour. In newly diagnosed FLT3 positive AML patients who are unfit for induction chemotherapy, would you consider FLT3 inhibitor plus a hypomethylating agent, or would you use hypomethylating agent plus venetoclax or the triplet?
I personally believe that in my country I have only hypomethylating plus venetoclax for unfit patients newly diagnosed. So I cannot use FLT3 inhibitor plus inhibitors plus azacitidine. We can use inhibitors just in relapse refractory population. We can use FLT3 plus 3 plus 7, but it is the midostaurin. Personally, I hope that the triplet will be probably the future, not in this moment. And in relapse refractory population, when I have FLT3 inhibitor, I prefer to use FLT3 inhibitor and potentially with decitabine. That's my suggestion.
Okay.
I cannot use the inhibitor from the beginning.
Okay. Another question here about the use of gilteritinib in maintenance post allogeneic stem cell transplant. What's your experience with that? Post transplant maintenance.
Yeah, we are using extensively gilteritinib for maintenance post transplant. The ADMIRAL trial was the first trial in the world that permitted the use of the gilteritinib in the maintenance post-transplantation. And that's made possible the registration of the drug for maintenance post-transplantation. And so in this moment, gilteritinib is the more common TKI inhibitor for FLT3 in the transplanted population. I suggested every time to my patients, even if they are MRD negative post-allogeneic bone marrow transplantation, if they are fit and they don't have a grade 3, grade 4 graft versus host disease, to start immediately not 120 but 40 milligrams of gilteritinib 2 or 3 months after the completion of the transplantation. So I personally suggest to use extensively gilteritinib maintenance in however is the outcome high risk population of relapse. And this was associated with a prolonged event-free survival post-transplantation, particularly in high-risk population.
So you said you start with 40 milligram and then you escalate to 120?
Yeah, I prefer to start with 40 because at the beginning, after a transplantation, the hematopoiesis is still low, the general hematopoiesis. So it could be better to be cautious, to be quiet, and then eventually when you are sure that the transplantation has been taken and the hematopoiesis was plenty, I could increase if necessary. Personally, prefer. You remember when we have done the dose finding, there was a lot of people responding to 40 milligrams. So the registration drug is 120, and we use these. But the drug has a long half-span. It takes more than 24 hours to be completely eliminated by the body. So there is a small amount of accumulation of the drug weekly. So 120 is sufficiently and probably necessary to block the FLT3 when you get a lot of FLT3 positive leukemia. But when you reduce, you shrink the leukemia, you can probably reduce also the amounts, particularly in the subset of transplanted population.
Okay. Okay. So I have a question relating to the dose. So I saw in the ADMIRAL trial, after 1 month of 28 days of Gilteritinib, if CR is not achieved, you increase the dose to 200 milligram, which is 5 tablets. So how did that affect the CR by the second cycle?
This again was an ADMIRAL experience. No, in the Chrysalis experience clinical trial. We grow up in the dosage, getting 120, then getting 200, then we getting 340 in the dose finding, and we don't find great toxicity. It was only when we reach more than 400 that we get some toxicity, probably related to the drugs. So the range, the safety range of use of Gilteritinib is quite large. For 80 milligrams, 80 milligrams, where we get some response, to 200 when we increase the response, but getting probably a bit of more intolerability. And 120 was the best compromise. High level of response, very low difficulty, and highly tolerability. So that was what we decided to use 120 because it was absolutely well tolerated. If you have no complete response and you would like to reach 200 milligrams, it's absolutely safe. You can do that. You can do it absolutely in the majority of patients. Please check eventually additional mutational, because if you are not able to block completely FLT3 with 120, it is probably there are some other mechanisms with conference resistance or less responsiveness. I personally believe that 120 is totally plenty to block the FLT3 signaling.
Okay. So I have, I see a question here from Dr. Apostolidis. So, are there any particular mutational profile associated with better response in patient with FLT3-ITD?
The question is, FLT3 inhibitor have generally modest activity in acute myeloid leukemia, correct?
Yes. Are there any
particular mutation profile associated with better response? This is true. There are some mutations that conference resistance, but not too much to Gilteritinib. This is more related to sorafenib and to AC220, quizartinib, not for Gilteritinib. Gilteritinib is quite able to bind the majority of the mutation. Until now, we don't have an extensive study of particular mutation conferring resistance. We are doing, but not in my knowledge is associated with less responses. Better response, the majority responds very well.
Okay. But any additional mutations that, I mean, like DNMT3A or TP53?
Yeah, of course. But the P53 is not too much associated with FLT3 mutation. We get very rare cases. There is a DNA methyltransferase 3A, which is absolutely associated with the FLT3, and EDH1, EDH2 are associated with the FLT3 mutation, and they are extremely sensitive. EDH1, EDH2 are sensitive. DNA methyltransferase 3A are less sensitive in the context of FLT3 positivity.
Okay. So I see another question here. In the frontline setting, do you see the utilization of these novel agents in the frontline therapy of AML? For example, the use of venetoclax plus hypomethylating agent plus FLT3 inhibitor, or other combinations such as gemtuzumab.
Dear Ahmed Alaskar, this is our dream.
Yeah, okay.
This is our dream. Dear Alaskar, we would like to arrive at this point. No chemo, no transplant. Until now, it's difficult, but there are some initial in relapse refractory population, some initial observation. I'm currently using venetoclax plus HMA plus anti-CD123 in my institution. I'm using venetoclax plus HMI plus idazanutlin, and we are also using venetoclax plus fludarabine-based regimen in first line as a GMEMA cooperative study group. The results are very good, but we have to test in a more randomized and more extensive one. I don't know if we have time to test all this combination. Personally, I believe that this combination that you suggested, the venetoclax plus HMA and FLT3 inhibitor, could be the best to be treated, to be tested.
Okay.
But we are now moving to research area. This is a research area.
Okay. Looking at the questions here. So just a quick question. If you use Gilteritinib in maintenance, for how long would you give it for? 2 years?
We take for 2 years. The majority of the patient has to be treated for 2 years. You can eventually reduce the 120 milligrams can be reduced during the meantime. The second year, usually we try to reduce if the patient is not tolerating very well the drugs, particularly to recover the normal hematopoiesis and the lymphopoiesis. Remember that FLT3 is also expressed in lymphoid population, so we need to get also recovery in the lymphoid population after allogeneic bone marrow transplantation. If the patient tolerates very well, we can also prescribe more than 2 years the treatment. So at the end of 2 years, we continue to treat the patient usually 40 milligrams a day.
40 milligrams, okay.
40 after the second year.
After the second year, okay. So I see here a comment from Dr. Mansour. He said that probably the NPM1 DNMT3 FLT3 positive had a better response in the ADMIRAL trial. Can you comment on that, Dr. Martinelli?
Yeah, it's a very sophisticated balance between NPM1 FLT3 and NPM1 FLT3 and DNA methyltransferase 3A. Personally, I believe that DNA methyltransferase 3A, whatever is the background of genomic background conference and this male worsening outcome. So if you go back to the ASCO meeting Levy's presentation, but also during this ASH meeting, you find out that the DNA methyltransferase free A is associated with a bit worsened response, and that will be something that has to be probably correct.
Okay. Dr. Martinelli, another question. When do you think the results of the Gilteritinib plus 7+3 will be available? When do we expect that? Next year, maybe? In ASH next year? Or
no, it takes more, because if I know correctly, the German and Netherlands groups make the randomized clinical trial. It depends where, but in Europe, I'm talking about Europe. The German and the Netherlands groups are now conducting an extensively randomized clinical trial versus midostaurin. So 3+7 plus Gilteritinib will be probably available. I suppose at the end of the next year or the middle of next year in Europe. EMA takes a lot of time to approve the drugs in Europe, since we have to pay with a public health system. So usually EMA take a lot of time to approve.
okay, so you think 2 years maybe?
At the end of next year.
Okay,
could be.
That's great. That's great. So another question here: if your patient was diagnosed with FLT3 mutation, and at the time of relapse, the result of the FLT3 ITD is not, the FLT3 mutation is not available, would you start a FLT3 inhibitor on relapse? I would say I would wait for the results. What do you think, Dr. Martinelli?
No, I try immediately to give the patient a FLT3 inhibitor. I don't wait. I don't wait for confirmation. Depend how long it takes confirmation. Usually in my country, it takes 3 days to get a confirmation for FLT3. But I prefer to start FLT3 inhibitor on relapse as soon as possible. You put. Sorry.
You wouldn't wait for 3 days?
Yeah. We do an extensively networking of laboratories that make FLT3 assay in 3 days. So we get the answer in 3 days, but usually 3 days nothing. We can wait 3 days, but I don't like to have a high level of white blood cells. I prefer to make a FLT3 inhibition as soon as possible to block the high level of FLT3 blood cells who grow up in a short time.
But you can use hydroxyurea, for example, just to mean time to control.
Yeah, but it doesn't work so well. No, you are right. We can use hydroxyurea and purinitol, but it takes more time. If you use a FLT3 inhibitor, you get the patients immediately under control in the majority of the cases.
Okay. I see another question here from Dr. Mansour. It's very active today. So in the dose more than, thank you very much, Dr. Mansour. In the dose more than 120, was there any difference in the PK/PD studies? And so
that's a good question. That's a good question, Dr. Mansour. It was evident that growing up than 120, we get accumulation of the drug. After 1 week, we get a double PK/PD of Gilteritinib in the blood level. Phosphorylation better. Dephosphorylation of FLT3 was complete for 24 hours. We get dephosphorylation of FLT3, totally under control. The signaling, switch off of the signaling. So it is possible that more than 120 milligrams could increase the inhibition of FLT3 signaling, but the majority of the cases we were able to demonstrate that the 120 is sufficiently to do the same. So going up, you probably, you know that the drug has two other targets. And probably increasing the dosage, you switch off AXL tyrosine kinase, which is another important tyrosine kinase that is associated with proliferation or hyperproliferation in acute leukemia also. So it could be probably a matter of off-target, off-fleet-free target of the drugs, which can be used. But the 120 is totally sufficiently to obtain a complete switch off of the signaling.
So until we have more questions, I see a question here about the QTC prolongation. Do you think that this is an issue when the dose is more than 120?
Adele, no. QT prolongation was a problem of other drugs, including, for instance, Quizartinib. But not for this drug. There is no QT prolongation with Gilteritinib. So you can increase the dose in a safety way.
Okay. So until we have more questions, I just want to tell you my personal experience with Gilteritinib. I had a young lady with relapsed refractory FLT3 ITD positive AML who failed 2 lines of salvage chemotherapy. So she failed FLAG-IDA and then VB16 cycle, which is a dose intense chemo. And afterwards, we were able to give her compassionate Gilteritinib. After cycle 1 with 120 milligram per day, her blast in the bone marrow went from 90% down to 10%. So as per the ADMIRAL trial, it was recommended to increase the dose to 200. So I increased the dose to 200. And at the end of the second cycle, she achieved a marrow blast of 5%. So we take her, she had a MAT-CEP and she underwent allogeneic stem cell transplant. And currently she's day plus 40 post-transplant and doing well. Alhamdulillah.
Start Gilteritinib in maintenance. My suggestion for this case, which is a classical canonical.
Yes. We are waiting.
Start as soon as possible. Sorry.
Yes, we'll do that.
Are you hearing me?
Yes, yes.
So that is a canonical situation. Personally, I take a bit of more time to put the patient in transplantation. I prefer to use Gilteritinib for 2 or 3 or 4 months before transplantation. You understand? No rush immediately. I don't rush immediately to the transplantation. I prefer to take the patients with a prolonged exposure to Gilteritinib before transplantation to shut off the leukemia FLT3 positive as much as possible. I know you are afraid to transplant, to lose the transplantation moment, but I personally take the patients in Gilteritinib. I believe in Gilteritinib, and so I take the patients for 3-4 months before transplantation, and then transplant the patients. However, if you transplanted the patient with MRD positivity, you have to start the maintenance therapy as soon as possible. The patients tolerate 40 milligrams or 80 milligrams of Gilteritinib. That's my comment.
Thank you very much. We are planning to do that starting here in maintenance soon.
Okay. I would like to thank all the participants. I would like to thank for this excellent opportunity, and have a nice New Year. Happy New Year. Merry Christmas. For Europe is important, and also Happy New Year. The next year, we hope to get a better situation that we have in the 2020. I wish all the best for you and for your countries and for your patients, and have a nice evening and night. Bye-bye.
Bye-bye. Thank you.
Salim.
Thank you very much, Dr. Martinelli.
Bye-bye.
I want to thank
Thanks
Dr.
a lot.
Martinelli.
Thanks a lot. Bye.
So, and I thank Dr. Martinelli for this elegant talk today, and again, want to thank the SSBMT for this opportunity, and want to thank the organizers and Astellas for their support. And I would like, Dr. Askar, you want to say, or?
No, go ahead.
So I would like to invite you to the next webinar next week, inshallah. We have a distinguished speaker, Dr. Theodoros, who will talk about treating relapsed refractory Hodgkin lymphoma next week at the same time, Saturday at 9 p.m., 26th of December. Inshallah.
Great.
So,
thank you, Salim.
I think we'll conclude here. Thank you very much for being with us, and hope to see you next week, inshallah.
Excellent. Thank you.